Hello everyone, for this lecture we will be discussing hematology and neoplasm, which is covered in chapter 24. These are the objectives that you can find in your syllabus. We will start off with a bit of a refresher, the hematologic system. Let's break down the concept of cellular regulation and how it relates to our blood. So cellular regulation is the way our cells grow, multiply, and do their job in the body. And the hematologic system, which includes the blood and tissues that make blood, this process is really important. There are three main types of blood cells, right? Red blood cells, RBCs, platelets, and white blood cells, WBCs. Red blood cells, they carry oxygen and nutrients to our tissues and remove waste. Platelets help with blood clotting, and white blood cells help fight infections. So all these cells start from one type of cell called a stem cell, which you can see on the right-hand side, that picture right there. Special proteins like erythropoietin, or EPO, and thrombopoietin, TPO, help guide this process. So for example, erythropoietin helps stem cells turn into red blood cells, while thrombopoietin, that helps stem cells turn into platelets. Sometimes, problems can happen in this process, right? Like producing too many or too few cells. This can be caused by things like infections, injuries, or even genetic factors. These issues can lead to different blood disorders, which is why understanding cellular regulation is so important. Neoplastic disorders, these are conditions where cells grow uncontrollably, and this includes cancer. Cancer happens when the body's normal cellular regulation goes wrong, causing cells to multiply in ways that they shouldn't. So we want to think about cancer in children. So children with cancer, and their families, they face a lot of fear, emotional stress, and changes in their life. So you really want to think about that psychosocial impact, them possibly being isolated from their friends, struggling with school, trying to be socially accepted, especially during the teenage years, also independence-wise. So while survival rates are improving, cancer in children, they have a big impact, on their emotional well-being and development, which makes our responsibility as nurses much more important in regards to providing that comfort and support and education to these patients and their families. Variations in pediatrics. So at birth, a baby's hematologic system should be intact and functional. However, there are some important changes in how the body produces red blood cells, hemoglobin, and how it stores iron during the first few months of life. So RBC production, that actually starts at 8 weeks in utero, mostly in the liver, and it continues there until just before birth. So after birth, the kidney takes over the role of producing that erythropoietin to help make red blood cells. When it comes to hemoglobin, babies have three types, so hemoglobin A, F, and A2. In the first few months, babies have a lot of hemoglobin F, but this doesn't last long. By 6 months, the body mostly produces hemoglobin A, which is more effective at carrying oxygen. The baby's liver also stops making blood cells, and the bone marrow and the long bones takes over. And then now iron, that's another important factor. Babies get iron from their moms during pregnancy. So you want to think about premature infants. They miss out on some of that iron transfer because they are born earlier. Around 2 to 6 months of age, infants, they may experience physiologic anemia, meaning that they might have lower levels of red blood cells because their iron stores from their mother are running low, basically. So to prevent this, babies need to get iron from breast milk or iron fortified formula in the early months, and when they start to eat table foods, solid foods later on as well, they can get that iron. So iron intake, that's also important during adolescence, as teens go through that rapid growth and need more iron to keep up with their body's demands. So you can see in the bottom right corner this chart that you can find in your textbook, how it compares childhood cancer compared to adult cancers. So in kids, most cancers start in early tissues like blood cells, nerves, or bones, which can lead to conditions like leukemia, brain tumors, and lymphomas, which we will be discussing later on in this lecture. Adult cancers usually start in the skin or organs and are called carcinomas. The most common cancers in children are leukemia, brain tumors, lymphoma, neuroblastoma, and others like Wilms tumor or bone tumors. When it comes to symptoms, children with cancer, they often show signs from problems in blood cell production or because the tumor is pressing on nearby organs. For example, changes in blood cell production can cause tiredness, pale skin, easy bruising, or frequent infections. If a tumor is pressing on something, it might cause pain in the bones or the stomach or other areas of the body, maybe swelling or some type of unusual drainage. So, us as nurses, being aware of these symptoms can help with that early detection and help get kids to be diagnosed quicker and get the treatment that they need. So, let's talk about common medical treatments. Blood product transfusions. So these are often needed for kids with serious conditions, like severe anemia, trauma, or bleeding disorders. There are different types of blood products that you may have come across or learned about in previous clinical rotations or theory classes. So there's packed red blood cells. You want to think for anemia, maybe whole blood for severe bleeding, platelets for a low platelet count, so thrombocytopenia, and fresh frozen plasma for conditions, like hemophilia. As a nurse, you want to follow your hospital's protocols. It may differ depending on that hospital, organization, institution. So just always, I think regardless of what institution, you're always going to do a 2RN check. You want to check the kid's blood type with the blood product that is given before starting the transfusion. You most definitely will check vital signs before, during, and after. You want to monitor for signs of reactions to that blood product, such as fever, chills, or trouble breathing. So if you notice any of those issues, you want to stop the transfusion immediately, then start running that normal saline that you have wide in when you prepare the tubing. Sometimes, kids, they may need pre-medication with maybe Benadryl or Tylenol to help reduce the chance of reactions before actually receiving that blood. So it just depends. Central venous catheter and implanted port, another type of medical treatment or a line that may be placed for kids with hematologic disorders. So a central venous catheter, CVC, you may have seen this or worked with it before. It's that special IV catheter, right? That's inserted into a large vein that leads directly to the central circulation near the heart, which you can see on the left corner picture. You can give medications, fluids, blood products, TPN, when those children that need more long-term treatment, such as having cancer or some other type of blood disorder. For kids, who need that continuous IV meds or maybe nutrition, the central line that provides, a reliable access point. But you also want to think about complications, if they start to have experience shortness of breath or chest pain, that could be a sign that there's air entering into the catheter. So that's an emergency. If that's the case, you'd want to have, the kid lie onto their left side and then notify the physician immediately, page them stat. You also want to think about infection at the central line site. So CLABSI, it's very important to keep that dressing clean and dry, to perform sterile dressing changes, according to your hospital's policy. Maybe once a week, and PRN, as needed. If it gets soiled or dirty, you always want to monitor, for signs of infection, at the site. Is there any redness, drainage, and are they febrile? Those are all signs of infection. And when you access the line, when you administer the meds, change the dressing, anything of that sort, you want to use sterile technique to prevent any type of organism to travel within or get to that site of the central line. And then on the right hand side, you can see an implanted port, or it's also called a portacath. A lot of kids with cancer have this type of port. I have never honestly accessed one before, but you can see how there's a specific needle that you need to use that has like a 90-degree angle so that you can access the port through the skin. But yeah, central lines are more common on other various units. Okay, let's talk about chemotherapy. So to understand, how chemotherapy works, it's helpful to know the cell cycle, which I included the picture there that's in your textbook, which is, that process of how all cells go through to divide and make new cells. And the cell cycle has 5 phases. I'm sure you guys have learned about this before. The G0 phase, G1 phase, S phase, G2, and M phase. Chemotherapy, the drugs, they work differently in different ways depending on the phase of the cell cycle. So some drugs may be cell cycle specific, meaning, they work during a specific phase, while others may be, cell cycle non-specific. So it can affect the cell at any point in the cycle. There are many chemotherapy protocols that use a combination of drugs to target different phases as well, which helps maximize the destruction of the cancer cells. But you also want to think about, however, chemotherapy doesn't only harm the cancer cells, it can also affect those normal cells that are rapidly dividing, like those in the bone marrow, digestive system, reproductive system, and hair follicles. So that's why when children or adults, any patient that goes under chemotherapy, they have those side effects like the low blood counts, infections, nausea, vomiting, mouth sores, the hair loss, and pain, especially as well. In the long term, it can also cause problems such as dental issues, maybe hearing and vision changes, growth delays, hormone imbalances, and possibly even an increase of developing cancers later in life. So us, as we keep learning about it, and if you decide to work in the hematology oncology type of unit, it's just important for us to be aware of those side effects and how to help manage these kids, to support them and help again, like, promote their overall well-being, as we discussed earlier. All right, and then now radiation therapy. So they use that high energy radiation to damage or kill cancer cells. It affects cancers and rapidly growing cells. It can be used as a curative, maybe in addition to chemotherapy or surgery, or prior to surgery, or as palliative treatment. It can help shrink that tumor. Just like other therapies or medical treatments, these have adverse effects as well. So, as listed on the PowerPoint, fatigue, nausea, vomiting, oral mucositis, myelosuppression, and alterations in skin integrity. And then, just like chemotherapy, these have long-term complications as well. It just depends on that area of the body that was directed with the radiation therapy. I listed some of those long-term complications, and then also some of that protective gear that they may use during radiation therapy, and how you see how it's more kid-friendly with like the Minnie Mouse, and they decorated like as I wanted to say Avenger, but I don't know what type of superhero that is. But yes, there's a picture there. And then let's move on to hematopoietic stem cell transplantation, or HSCT. This is a procedure used to treat childhood cancers such as leukemia, lymphoma, and neuroblastoma. In this type of transplantation, stem cells, they're infused into the child's body through intravenously. But before this, the child, they need to undergo high dose chemotherapy or maybe radiation to help kill cancer cells, which that as a result, that also destroys or like depletes their bone marrow. After this, then the transplanted stem cells, they'll move into those empty spaces that the chemo and or radiation helped provide in the bone marrow, and that will start producing normal blood cells again. That's the goal. This is typically not the first treatment for cancer. It's usually used when the type of cancer that the patient is diagnosed with is hard to treat or has come back after their initial treatment. There are two types of HSCT, which is autologous and allogenic. Autologous, this involves using the child's own stem cells. However, there's a higher risk of the cancer coming back since the cells may contain some cancerous cells. Allogenic HSCT, this involves using stem cells from another person, like maybe a sibling or an unrelated donor. The donor cells, they don't need to match the child's immune system, called HLA matching. Close match, reduces that risk of complications like graft rejection when the body rejects the new cells, and graft versus host disease when the donated cells attack the child's body. So while HSCT can be life saving, it comes with risks. In the short term, the that patient, that child that may face infections or electrolyte imbalances, bleeding, or damage to organs, skin, and mucous membranes. Long-term complications, you want to think about issues with growth, fertility, bone health, and an increased risk of developing other cancers and later in life as well. So that's HSCT. Let's move on to palliative care. So this is a type of care that focuses on providing relief from the symptoms, pain and stress of a serious illness such as cancer, rather than trying to cure the disease itself. The goal is to improve the quality of life for both the patient and their family, no matter what stage of illness they are in. It's not just for end of life care, right? This is not hospice. It can be given alongside curative treatment, or when a cure is no longer possible, palliative care can be implemented. This can help manage physical symptoms, like I mentioned, pain, possibly nausea or difficulty breathing, as well as emotional, psychological, and spiritual support as well for the patient, and again their loved ones. This, for us as nurses, we'll be involved with assessing and managing those symptoms, helping provide that emotional support within palliative care, and also education, ensuring the patient and the family, they understand the treatment options. It really, palliative care, it involves a team approach, including the doctors, nurses, social workers, chaplains. We work together to offer that holistic type of care that helps address the patient's needs in a more compassionate and, again, supportive way. Lab and diagnostic testing. So let's talk about complete blood counts. So CBCs, so you guys have probably helped drawn it or seen results in patients' charts. So just to review, normal values, they vary from age and gender. So I just listed the tables that the textbook provides of the different values. So not that you have to memorize every single age range within their normal values for each type of what it measures, like hemoglobin, white blood cells, platelets, but I want you to get a general idea if you can see the big differences within the ranges. Is there a big difference? Is it similar? So definitely take a look at that. Within a complete blood count, there are a lot of different aspects to it of what it measures. So I just highlighted the main three that you want to look for when you are thinking about a hematologic disorder, and then, cancer. So hemoglobin, we talked about that, white blood cells, and platelets. Let's review hemoglobin again, just very briefly, how we mentioned, this is a protein in the red blood cells, right, that carries the oxygen throughout the body. In kids, normal hemoglobin levels, like I mentioned, they vary by age. So, for example, I listed them for you here. You see how the newborn levels are 14 to 24, opposed to older kids where it's 11.5 to 15.5. When hemoglobin, those levels drop too low, that's called anemia, which you probably have learned before, and that just means that the body isn't getting enough oxygen. So if before even drawing a CBC, you can assess for symptoms of low hemoglobin you can assess symptoms of anemia, such as what fatigue, paleness, shortness of breath, dizziness, and a rapid heart rate. This can be caused by iron deficiency, sickle cell disease, thalassemia, or blood loss from injury or some type of surgery. So typically, from the hospitals that I have worked at, children's hospitals, if a kid's hemoglobin is less than 7, regardless of the age, they will often need a blood transfusion to help restore, the oxygen carrying capacity of that blood. So this is our responsibility to be able to monitor for those symptoms. We don't just rely on the blood, the CBC results, right? Who knows if we're going to get those results in time or if they're accurate. So that's something that you really want to think about and look for, and just to review those lab values too. All right, let's talk briefly about white blood cells, or WBCs. These are important for fighting infections, right? We mentioned that before. These levels, they vary depending on ages, just like the hemoglobin and the platelets that we're going to be talking about in infants. So you see the different ranges that I included for you. Infants, they're 6 to 18,000. Compared to older kids, 5 to 15,000. So you can see how the ranges differ a little bit. If white blood cells are too low, that is called what? What do you remember? Leukopenia, right? So if it's too low, they're at a higher risk for infections, and you want to look out for symptoms. Think about what are symptoms of low levels of white blood cells. Possibly fever, mouth sores, or increased fatigue. When they are low, especially if neutrophils, which is, a type of white blood cell, you call that neutropenia, you want to provide special interventions or special types of care to avoid those infections, right? So you want to think about neutropenic precautions, especially in the hematology and oncology unit. A lot of these kids, they have low white blood cell counts, so then they will be on neutropenic precautions, also known as reverse isolation. So, say if you're walking around because you didn't get your flu vaccine with a mask. So, before going into this neutropenic precaution room, you are going to want to replace the mask, right? So, you're trying to protect the kid from any types of organisms, germs from outside. So, that's the way you want to think about it. So, neutropenic precautions, I think want to implement strict hand hygiene for everyone. Avoiding crowded places, you want to educate about that. Wearing a mask when the kid is outside of the room. If they're going to the playroom or just outside into the patio area for some fresh air, they should be wearing a mask to help prevent that infection. Limiting visitors as well, and then like always, just monitoring for signs of infection. Is there any fever, redness at like their central line? If white blood cells are elevated, what is that called? Leukocytosis, right? This signals as an infection as well. So you want to look out for what type of symptoms. Think about it: fever, pain, or swelling at that infection site. So in these cases, you want to identify that source of infection and start treatments like antibiotics or antivirals, with the goal of helping fighting off that infection and decreasing their white blood cell count. So this that's white blood cells. Let's talk about platelets. So these are those tiny cells in the blood, that help stop bleeding by forming clots, right? So normal platelet levels, it can vary, but they're typically between 150 and 450,000. I also included the different ranges. Again, it varies in ages. So when platelet levels are too low, what is that called? Thrombocytopenia, right? Think about the symptoms. They may have trouble stopping the bleeding. They will be easily bruised, tiny red or purple spots on the skin. It's called the petechiae, right? So you can see the picture right there that I included. Nosebleeds, they might have bleeding gums. Typically, if like the platelets fall below, just depending on the hospital, like I think 10 to 20,000, then a platelet transfusion will be ordered, but especially if they're active bleeding too. You also want to think about, education and avoiding injury, monitoring for signs of bleeding and keeping that child in a safe environment. So meaning like avoiding injury, non to avoid contact sports such as yeah, football, right? Like it's like a direct contact with other bodies. When platelet levels are too high, what is that called? Thrombocytosis, right? That can lead to clotting problems. You want to think about symptoms again: headache, pain, or swelling in the limbs, shortness of breath. If you notice these, this is when you want to notify that physician that is within their uh, team of care, so that they can look or rule out for underlying issues, like an infection or some type of blood disorder. So we always, with platelets, we want to always be monitoring for bleeding with low platelets and with clotting with high platelets. Um, that's platelets. All right, so diagnostic testing, this can be found in your textbook. Not that you have to know and memorize all of these different types, but just to go over the more common ones and the ones that I have commonly seen as well within my practice. So it's just important for us to understand, the different common diagnostic tests that we can help to diagnose the different types of hematologic disorders, right? So let's talk about bone marrow aspiration and biopsy. So this test, it takes a sample of bone marrow, usually from the hip bone, and it checks for diseases like leukemia or anemia. And before the actual procedure, you want to make sure that you get the child understands and has consented. Of course, depending on their age, but just doing your best. So, letting them know, like prep them ahead of time, getting child life involved, so that they can be better prepared for it, and parents as well. And then after this type of testing, you want to monitor for, any bleeding or infection and pain at that site where they get the aspiration. What about CT scan? You guys have heard of that before. That's an imaging test, right? That uses x-rays to create that detailed picture of like how it is inside of the body. That helps to see if like tumors or abnormal cells are present in areas of the body, such as, the chest, the abdomen, lymph nodes. And then this is also something that you'd want to try to explain to the child ahead of time. What about lumbar punctures? So it's also known as like a spinal tap. And this type of testing, it collects cerebral spinal fluid, so CSF from the spine, to check for infections or cancer cells in the brain or spinal cord, especially in leukemia. And this one, I think we talked about it before, how they will keep the kid in that fetal position or that curled up position during the procedure. And then after, you want to monitor for any headaches or signs of infection at the site. What about MRI? That uses those magnets to create the image of the organs and the tissues inside the body. It is really great for looking at, the brain, spine, or bone marrow for any possible types of cancers or infections. This one is where the kid needs to stay still for a longer period. So you want to think about those kids that may have are cognitively impaired or just younger, and knowing that they're not going to be able to stay still. And then you want to think about how, depending on what type of MRI machine that the hospital has, that if it's like a more closed system, they can start to feel claustrophobic and get scared and anxious. So they may have to be sedated. Maybe moderate sedation, or they may be under general anesthesia. It just depends on the patient themselves. Yeah, so just basically with all these tests, you want to try your best to explain that procedure to both the parent and the kid, and then monitor for any types of complications as we talked about. All right, iron deficiency anemia. Let's talk about this. This is when the body doesn't have enough iron to make hemoglobin, that part of that red blood cell, right, that carries oxygen. So this is most common between the ages of 12 to 24 months, so 1 to 2 years old, and during adolescence. So a key contributor to this, why we have the picture too of the cow, is cow's milk. Especially when it's consumed too early or in excess amount, it doesn't provide enough iron for that growing child. So when the body lacks iron, it can't produce enough hemoglobin. This means the blood can't carry oxygen, as efficiently, which then leads to that fatigue, weakness, and even possibly delays in growth or cognitive development. So you want to look out for signs of, irritability, dizziness, weakness, shortness of breath, pallor, and fatigue. In severe cases, sometimes the nails may even be more concave. I think they call it like spooning. To treat iron deficiency anemia, we often give iron supplements like ferrous sulfate. If it's severe, then a blood transfusion may be needed. It's just important to educate families about iron-rich foods, during their well-child visits. You want to think about anticipatory guidance, what type of foods are iron-rich, such as red meat, spinach, fortified cereals. And you always want to think about and educate about monitoring for safety. Again, that dietary guidance, and then supplements as well. Aplastic anemia. So this is a serious condition where the bone marrow, it just stops making enough blood cells that leads to pancytopenia, or I think I said that wrong. But yes, that the low levels of all types of blood cells, so the RBCs, WBCs, and platelets. This can be either inherited, like Fanconi anemia, or acquired. Acquired aplastic anemia, that's often caused by an immune system attack on like the bone marrow, but the exact trigger is often unknown. Other causes that can include, exposure to toxins, certain medications, maybe a virus, or radiation. These kids, they are at a high risk for severe infections and bleeding, which can be life-threatening, right? If you think about it, this is because they don't have enough of those white blood cells to help fight infections, and they're low. Their platelet count is so low that they're more prone to bleeding, right? So the treatment, this may involve that bone marrow stem cell transplant that we talked about, HSCT, from either a matched sibling donor or immunosuppressive therapy, with medications like high dose cyclophosphamide. So regarding when we are doing like our assessment, you want to take that history. You want to look for those risk factors such as the exposure to toxic substances, medications, radiation, like I mentioned earlier. And you also want to ask or assess for, like the easy bruising, nosebleeds, bleeding gums, heavy periods, fatigue, headaches. You just want to think about, what are those symptoms that are associated with a low platelet count, low white blood cell count. Excuse me. And then within lab results as well, right? Like most likely a CBC will be ordered, so you want to look at the ranges and see if there's any abnormalities there. In terms of management or treatment, safety is that priority. They need to be protected from injury because their blood, it just doesn't clot properly. They're at that risk for bleeding. You want to administer blood products cautiously as well, doing the double check RN, making sure that you are following all of those steps, the hospital policy. You can also refer families, and the kids to resources such as I think your textbook, it mentions it says aplastic anemia and myelodysplastic syndrome international foundation. So that helps with support and education that they can provide to those families. So it's just super critical to monitor these kids closely. So because they just can deteriorate quickly and they're at a higher risk for so many things. So yes, you just want to think about protecting their health. Sickle cell anemia. So this is a genetic disorder where the body produces an abnormal form of the hemoglobin known as hemoglobin S. So instead of the normal hemoglobin A. So in sickle cell anemia, the red blood cells, they become more rigid and sickle shape, hence the name. And you can see that picture on the right hand side. That is due to that mutation in that hemoglobin molecule. So the sickling of the cells, it causes them to become less flexible and like unable to flow properly through the small blood vessels, which you can see in the next slide in a little bit. Just as a result, the blood flow, it becomes blocked, and that is what leads to that pain, tissue damage, and organ dysfunction. I know I mentioned how it's a genetic disorder, so this is an autosomal recessive pattern. Meaning, the kid, they inherit the sickle cell gene from both parents to have the disease. Um, if the child inherits only one sickle cell gene and one normal gene, that's hemoglobin AS, so they have the sickle cell trait, and they're carriers, but they usually don't have symptoms. This type of anemia, it affects 1 in 325 African American newborns, and 1 in 13 African American newborns have the sickle cell trait. So you want to think about complications. So this can lead to the pain crisis. Remember, we talked about how the blood flow is blocked. It can lead to other complications such as stroke, acute chest syndrome, trapping of the blood in the spleen, and infections. The sickle cells, they have a shorter lifespan, so that can lead to chronic anemia. So these kids are at higher risk for infection also due to the functional asplenia, so like the non-functioning spleen that I mentioned, how the trapping of the blood by early childhood. You want to think about the triggers for the crisis. So it can be triggered by infection, dehydration, extreme temperatures, physical exertion, and stress. When the cells, again, I know I mentioned it a couple times already, when it blocks that blood flow, it can cause that tissue hypoxia. So furthermore, it just leads to that pain and then that potential organ damage. For therapeutic management, that includes first and foremost pain control, hydration, oxygen therapy during those crises. Hydroxyurea, that's often used to help with reducing the frequency of those painful episodes, and blood transfusion, they may be needed as well. Stem cell transplants, they offer a more of a cure for some kids, especially those with a donor that is a matched donor that is a sibling. So, us as nurses, you want to be able to assess for those complications, and you want to know how to manage their pain. It's going to differ compared to managing like post-op pain. Let me show you the next slide. Just with the visual, and then more of the comparison of the acute versus chronic sickle cell anemia manifestations, and then like that blood flow that we talked about. That's sickle cell anemia. Let's talk about thalassemia. So this is a genetic disorder that affects how the body makes hemoglobin, the protein in red blood cells that carries the oxygen. Again, I know I mentioned that multiple times. This is inherited. It's an autosomal recessive pattern. So the kid inherits that defective gene from both parents, right? This is most common in Africans, Caribbeans, Middle Eastern, sorry, I put Easter on the slide, South Asian and Mediterranean descent. There are two main types. There's alpha and beta. So we'll focus, or your textbook focuses more on beta thalassemia. This one is more common. It can range from minor to major. So the major is the most severe and life-threatening one. In beta thalassemia major, that is where the body is not able to produce enough of the beta globin, the beta globin chain that's needed for hemoglobin. So that leads to severe anemia and that chronic hypoxia. So to help compensate for that low hemoglobin, the bone marrow, it works overtime. So it causes the bone to expand and causes deformities, which you can see on the right upper corner. So you'll see that picture has that frontal bossing, right? The prominent forehead, and the no, not the chin either. Just the forehead in that picture, and then it can also cause growth delays. So you want to think about how it can also lead to iron overload from frequent blood transfusions, which can also damage the heart and liver. Treatment for this, specifically beta thalassemia major, it involves regular blood transfusions that helps maintain those hemoglobin levels. But like we were talking about, it just leads to the iron buildup in the body. So to help manage that, they need that iron chelation therapy with medications such as, let's see what it says, deferoxamine or deferoxerox, that helps remove excess iron from the body. You want to monitor, the hemoglobin levels, right, from the CBC, your iron levels and growth, and then also always, just with all the different disorders that we're going to be learning about today, as providing education to both the patient and the family. You want to be able to teach the parents how to or just to understand, like the necessity of the blood transfusions, and if they get a subcutaneous chelation therapy, they need that, and if they're going to be the ones administering, they're going to need proper training and guidance with that as well. Let's move on to ITP, so clotting disorders, idiopathic thrombocytopenia purpura, or ITP. This is a condition where the immune system, it destroys platelets. So this leads to, think about it, easily bruising and bleeding, makes them more prone to bleed. Typically happens in younger children after like a viral infection, such as maybe the flu or varicella, so chickenpox. The immune system, it just mistakenly creates antibodies against the platelets, which are, again, thinking about the platelets, they're necessary for blood clotting, right? So when there's a lack of, then they are more at risk of bleeding. So when they drop, they're going to develop the petechiae, right? The tiny pinpoint hemorrhages on the skin that doesn't, when you press on them, it doesn't blanch. And then the purpura, we saw that on a different slide as well, that the larger purple spots, where the blood collects beneath the skin. So these can appear rapidly from about 24 to 48 hours. And in more severe cases, if platelet levels drop below 10,000, there's that risk for serious bleeding, right? Into the brain or vital organs. But it's more rare it's typically rare. Most kids, it just recovers spontaneously. Treatment is not typically needed unless the platelet count is extremely low, like I mentioned, the under 10,000. If it is under 10,000, then corticosteroids are typically prescribed as well for 2 to 3 weeks. That helps increase that platelet production. And then another treatment option is IVIG, so intravenous immunoglobulin. That can help boost the platelet count as well. What other things? So other symptoms that they may present with, epistaxis, so nosebleeds. You want to think about bleeding gums. We talked about that earlier as well, regarding low platelet counts. And then other things is just to for management of this. Other than observation, they're going to need those regular blood tests to monitor their counts. So it's really important to educate parents on the importance of following up and scheduling those appointments so that they can get their blood drawn in a timely manner and consistently, so that the providers can monitor their blood counts. And then also want to educate on avoiding meds like NSAIDs or aspirin, which can worsen the bleeding, right? This one too, with their risk of bleeding, as we talked about in the prior disorders and talking about platelets earlier, just education on preventing injury, right? So what are those things that I mentioned about the contact sports, right? Recognizing, and also educating them on recognizing, when there's severe bleeding, things like that. That's ITP. So let's do HSP. So Henoch-Schönlein purpura. This is a condition that most often affects young boys, and it usually develops after a viral or bacterial infection, particularly respiratory infections. This is a type of vasculitis, so the inflammation of blood vessels. This can be triggered by deposits of IgA, so an antibody, in the small blood vessels, mainly in the skin, joints, kidneys, and the stomach, abdomen. The most common type of HSP is a palpable purpura, right? This is often seen, like you can see in the picture right there, the legs and the buttocks, and it's raised. It's not just flat. These kids, they may complain of joint pain, abdominal pain, and sometimes they may have hematuria, so blood in their urine, and that can indicate what kidney involvement. Most kids, they recover on their own within a few weeks, but some cases this can lead to kidney problems, such as nephrotic syndrome or high blood pressure. So if this happens, further treatment is going to be needed, right? For severe pain, corticosteroids like prednisone that can be used. If there's kidney involvement, we may need to monitor the child's urine and blood pressure more closely. I Other than that, other symptoms, let's see. We talked about the hematuria, we talked about the joint pain, abdominal pain. For more mild cases, you want to focus on hydration and managing those symptoms. So just encouraging fluids, especially if the kidney is involved, if kidney function is normal, sorry. If the kid is having severe abdominal or joint pain, you want to administer, analgesics as they're prescribed. Corticosteroids can help, like I mentioned earlier, with the pain and the inflammation for the more severe cases. So those are some things to think about and to implement within your practice. And then let's talk about disseminated intravascular coagulation, so DIC. This is a life-threatening condition, as you guys have learned in probably previous theory classes. This occurs in those critically ill kids, if there's a complication of infection, septic shock, tissue injury, or cancer treatment. It's more, it's described as like that abnormal clotting throughout the bloodstream. So this consumes the platelets and clotting factors, leading to both clotting and bleeding at the same time. So the body starts forming clots in small vessels, and this causes that widespread tissue damage and organ failure. And symptoms that you would see with this is like the petechiae, the purpura, bleeding from IV sites, or even organs like the kidneys, so hematuria. You also may notice signs of poor circulation. So what are signs of poor circulation, right? Like weak pulses, delayed capillary refill, so cap refill over 3 seconds, tachycardia. So treatment, this is focused on just addressing that underlying cause, right? So antibiotics for infections, heparin to help prevent that excessive bleeding, blood products may be implemented within treatment as well for platelet transfusions, and clotting factors as to be administered too to help manage that bleed. So for us as nurses, our role is just to closely monitor this condition, assessing for the bleeding, the respiratory distress, and then the circulatory problems, right? For the poor circulation, you want to monitor their neurostatus as well. And urine output, that is going to indicate, organ involvement. And then, of course, monitoring lab values, the prolonged clotting times, the low platelet counts, and then any changes that we notice that we would need to notify the provider right away. That's DIC. Hemophilia A, this one is a genetic disorder. That's where the blood doesn't clot properly due to missing or deficient clotting factors. So this is an X-linked recessive condition. So this means it usually affects males. They inherit that defective gene from their moms who are carriers. The most common form of hemophilia in kids is hemophilia A. So this is that lack of factor 8. That's an essential protein for blood clotting. So without enough of this factor 8, so when a child bleeds, their blood doesn't clot properly, making that bleeding episode hard to stop. There are different levels of hemophilia, ranging from mild to severe, and in severe cases, bleeding can occur more often and be harder to control, right? So for example, like a small injury, like a paper cut, that's going to result in prolonged bleeding. And bleeding, it can also occur inside joints, leading to swelling and pain too. For management, The goal is to prevent bleeding and to manage those bleeding episodes. So, providing education and support regarding this for parents is very important again. So, um, just avoiding that high risk of injury, right? The contact sports, such as football, like we mentioned earlier. Instead, you can say you can offer more low contact activities like swimming or running, where there's no like body to body contact. But if bleeding does happen, the main treatment is factor replacement therapy. So that's where like that missing the intravenously the missing clotting factor is given to the child, and this will help the blood to clot properly to help in result control that bleeding. What other things? So regarding on like your findings, like what symptoms wise, manifestation wise, what you want to look out for is any recent bleeding or bruising, GI bleed, so like in the GI tract. So what are things like blood in the stool or hematuria, so blood in the urine, and again the petechiae, the purpura, so the small spots or the larger bruises, or maybe unusual pain or swelling in specific joints. But yeah, so just family support. You want to think again. I mentioned about the education support in regarding to helping parents to understand how to prevent the bleeding episodes, to manage it. Education is really important for this disorder. Okay, let's talk about leukemias. So the first one is ALL, or acute lymphoblastic leukemia. This is the most common type of cancer in children, especially in those 2 to 10 years old. This affects the blood and bone marrow, so this leads to an overproduction of the abnormal WBCs called lymphoblasts. Hence why it's called acute lymphoblastic leukemia. The cells are immature and they can't fight infections properly. So instead, they start to overcrowd the bone marrow, and that impairs the production of the normal blood cells, the RBCs, the normal WBCs, and platelets. So that's going to lead to what? If there's a deficiency, if they're being overcrowded and there's a deficiency, low levels of the normal blood cells, right? It's going to lead to anemia, infection, and bleeding issues. So, risk factors, it's more common in Caucasian children. Boys are more affected than girls. There's genetic factors such as having Down syndrome, and also previous chemotherapy treatments can increase their risk. Symptoms to look out for is fever without a clear cause, fatigue. Are they pale? Bone pain, that's due to the bone marrow expansion because of the overcrowding. The unusual bruising or bleeding due to the low platelets, right? The abdominal pain from the enlarged liver and the spleen. And then also headaches, maybe vomiting and seizures. So if the cancer has spread, metastasized to the central nervous system, they may have those types of symptoms. The prognosis of this type of leukemia, it just depends on factors such as like what their WBC count was at diagnosis. So if there was a higher count at diagnosis, that usually means that their prognosis is worse. Those kids that are aged from 1 to 9 years old, they have the best chances of remission. But if there is central nervous system involvement, right, like with those symptoms that I mentioned, the headache, vomiting, and seizures, that means that the prognosis has worsened. Treatment. So there are 3 stages of 3 main stages of leukemia treatment. So induction, consolidation, and maintenance. There's usually like a specific roadmap for each kid that is on some type of chemotherapy. So I included the chart there that has the different medications and the length of time for each of those stages that you can go over. And then for relapse, so after treatment, if the ALL returns, the prognosis is more poor. So in some of these cases, the HSCT, the hematopoietic stem cell transplantation, that may be needed for further treatment. What other things for this? In terms of when they initially get the labs and diagnostic testing, of course they're gonna get a CBC, and that's gonna show all those abnormal levels, right, of all those blood cells. And then bone marrow aspiration, that's going to help confirm that diagnosis by identifying over 25% of the lymphoblasts in the marrow, the bone marrow. And then the lumbar puncture, that's going to, how that gets the cerebral spinal fluid. So that will check if the central nervous system is involved within this ALL. Has it spread to the CNS? And then also another type of lab is immunophenotyping. So that helps determine the exact type of leukemia that this will help guide that treatment, that roadmap that I mentioned of what the providers are going to implement. So, in terms of nursing management, you really want to think about infection prevention, managing the pain, blood product transfusions is what we're going to be administering, and education and support, right? So, again, infection prevention, they're going to be on that neutropenic precautions most likely, or reverse isolation. They're at that high risk for infection. So, again, hand hygiene, that protective isolation, wearing the mask outside of the room are very critical for these types of kiddos. Managing pain, most of the treatments often cause pain, so especially in the bones and the stomach. So, what type of pharmacological interventions can we implement? Non pharmacological interventions. We've talked about this like during the first few weeks of theory class, distraction techniques, analgesics, any EMLA cream, the numbing cream. Will that help produce pain from, like the bone marrow aspiration and like the lumbar puncture that they got initially? And then also blood product transfusions. They're going to be having their blood cells monitored throughout, their chemotherapy treatment or whatever other types of treatments that they may be going under. So that's part of our responsibility of administering, and then also providing families providing education and support to them, so that they can understand better the disease and the treatment. Maybe home care when they're going home, and then what signs of infections to look out for, like recognizing that at home when they're not inpatient. That's part of ALL. Let's talk about AML, so acute myelogenous leukemia. This is the second most common type of leukemia in children. So this is typically, it affects more so adolescents more than younger children. This starts with the myeloid cell line in the bone marrow, where the precursor cells, so the myeloblasts, become malignant. Hence the name acute myelogenous leukemia, AML. They grow uncontrollably and replace those normal cells. So unlike ALL, this type of leukemia is more aggressive and it's harder to treat. So risk factors of this type of leukemia is that it occurs, the peak incident, it occurs in adolescence, right? And then genetic conditions, just like AML too, Down syndrome, but also Fanconi anemia, neurofibromatosis, and then Wiskott-Aldrich syndrome, and also Diamond-Blackfan anemia. I'm not too familiar with that one. So they're all at a risk of developing AML, and then the Hispanic children, they have a higher incident rate of being diagnosed with ALL. Patho-wise, so you want to think about how AML that affects, how I mentioned earlier, the myeloid progenitor cells in the bone marrow. So that leads to that production of the immature, non-functional blood cells. This, just similar to ALL, it crowds out all those healthy blood cells. So again, like those low levels, what is it going to cause? It's going to cause the anemia, the risk of infection and bleeding. So what are symptoms of that? Just keep for each of these disorders, you want to just remind yourself of, like what are you looking out for, and then the blood cell counts as well, and what are they called. So as they are invading and they're growing rapidly, these cells, it's going to spread to other organs, including, the liver, the spleen, lymph nodes, and the central nervous system. This type of leukemia, it is classified into 8 subtypes, so M0 to M7, which I'm not going to have you memorize, but just be aware that there are 8 subtypes. And it's just based on the type of myeloid cells, how they're like involved, and how it's differentiated into the cells that they are. This just helps like when it's classified like with the treatment approach. Prognosis wise, there's a long-term survival rate for these kids. It's about 50%. But treatment resistance and infection, those are common complications. And the treatment is typically more intense, and um, there's more treatment related toxicities as well that are more severe. What other things? Oh, so these kids with AML, they may present with a high white blood cell count. So that is called hyperleukocytosis, over 100K. So that is what their count may be at diagnosis. So this is a medical emergency. This is when it causes that venous stasis. So where the blood flow slows down, and that leads to a backup of those blast cells in the small blood vessels. So that as a result, that can cause hypoxia, hemorrhage, and potentially like a brain or lung infarction. So like the tissue death. Treatment for this is leukapheresis. So that's where it removes the excess white blood cells from the blood. So that may be that's going to be implemented. Treatment wise for AML is induction chemotherapy. That helps to induce like remission. So but it requires like that intense bone marrow suppression, and often they are hospitalized longer for a longer time, because in comparison to ALL, it's less responsive to treatment. But HSCT, the hematopoietic stem cell transplant, that is often implemented within this type of leukemia, but for certain subtypes. What other things? For nursing wise, like management wise, you want to think about just managing and think about infection control, like just like ALL, bleeding precautions as well, pain management, and then chemotherapy management and psychosocial support. So they all follow along the lines of what we discussed in ALL, so I won't repeat them. Let's talk about lymphomas. First, Hodgkin disease, or Hodgkin lymphoma. This is a type of lymphoma, so a cancer that begins in the lymph tissue. So lymph nodes, spleen, thymus, lymphomas, they account for about like 10 to 15% of childhood cancers, and they're divided into the two main categories. So this one is Hodgkin's disease. This one is characterized by the presence of Reed-Sternberg cells. So those are the abnormal B lymphocytes. So that's a type of white blood cell, right? This is where those cells grow uncontrollably in the lymph nodes and other lymphatic tissues. So it typically begins in one area of the lymph nodes and spreads to nearby areas as it starts to progress. So over time, it can invade other tissues in the body. So typically, this is more common in adolescents and young adults. It rarely occurs in kids under 5 years old. It's more common in boys. And then the cause, it's unclear, but EBV, so Epstein-Barr virus, that is thought to be a contributing factor, a possible link. There are different stages of Hodgkin disease. So there are four. Sorry, there are four different stages, and that's just based on how far the cancer has spread. So in your textbook, you guys can look at it of how it's classified. I'm not saying you don't have to memorize it, but just be aware that there are four stages. But in addition to the staging, it is classified with an A or a B. So A being no systemic symptoms, so like fever, night sweats, or weight loss, and then B is the presence of symptoms like I mentioned, the fever, night sweats, and unexplained weight loss. So there are different stages and then also different classifications. So just be aware of that. As far as prognosis, it's typically pretty good. There's a 5 to 10 year survival rate, over 90%. But it just depends on like the stage of disease, the size of the tumor, and whether there are like if it's A or B, like is there systemic symptoms or not. Treatment wise, it includes chemotherapy, maybe radiation therapy, and in case of relapse, is the hematopoietic stem cell transplant, HSCT. But common complications, from this disease, it can be secondary cancers like non-lymphocytic leukemia or non-Hodgkin lymphoma, which we'll discuss in the next slide, or liver failure. But that's more rare. At initial diagnosis, signs and symptoms to look out for is that weight loss, the fever, loss of appetite, fatigue, itching, so the pruritus, and then the painful swollen lymph nodes. So some of those are listed within the classifications of A or B. What other things? So when you do your actual physical exam, you may palpate for those enlarged lymph nodes. You can check for like liver and spleen enlargement. And then also there was probably going to be a tissue biopsy. That's within like the diagnostic testing for the Reed-Sternberg cells to help confirm the diagnosis. Nursing considerations for this disease is pain management, infection prevention. You want to think about nutrition because due to the anorexia and the weight loss, you want to provide that nutritional support to help maintain them to be intaking, more adequate calories. And then emotional support as well. That is Hodgkin. So let's do non-Hodgkin lymphoma. So this is that type of cancer that begins in the lymphatic system as well, which is part of the immune system. So this cancer results from that mutation in the B and T lymphocytes. So those are types of white blood cells as well that causes these cells to grow uncontrollably. So there's mutation in uncontrolled growth, and then spread. So this one can spread pretty quickly through the bloodstream, and that makes it rapidly growing and then more aggressive. This is a more aggressive cancer in children. Prognosis wise, it depends on the cell type. Is it B cell or T cell involved, and then the extent of the disease when it's diagnosed. So if it's a localized NHL, they have that, meaning that it has not spread, it has not metastasized. There's a 90% chance of long-term survival after treatment. But if it has spread, so if it has metastasized to other areas of the body, that can lead to secondary malignancy, so like another type of cancer, many years after treatment. Symptoms to look out for, so signs and symptoms that they may present with. So this lymphoma, it can develop quickly. So they often present with symptoms only a few days or weeks before the diagnosis. So you want to look out for signs of pain and swelling, so like lymph node swelling, pain in the abdomen or chest, GI symptoms such as abdominal pain, diarrhea, constipation, respiratory issues like increased work of breathing, facial swelling, or venous engorgement. So that can suggest like a mass in the chest that's pressing on the blood vessels. So that's known as a mediastinal mass, or a lymphadenopathy. So the swelling of the lymph nodes. Diagnostic wise, so they're going to do a lymph node biopsy, bone marrow aspiration, CT scan, and chest x-rays. Treatment wise, there's chemotherapy, and then if the cancer is not responsive to treatment, or if there's like a relapse, then an autologous bone marrow transplant may be considered to help treat this disease. So using the child's own stem cells, right? That's the autologous. Let's see what else. And then management wise on the nursing end, so you want to think about managing the chemotherapy side effects, supporting the infection or preventing infection, psychosocial support to both the patient and family, monitoring respiratory function, and pain management. So some of these are repetitive, so does not change this throughout. Let's talk about brain tumors now. So these are the most common solid tumors in children and the second most common type of cancer after leukemia. It can either be localized or high grade. So localized, that means the tumors are growing slower, and then high grade, it's more aggressive and fast growing. So the location and the extent of the tumor, that impacts how easily it can be treated or like the overall prognosis, so their outcome. The posterior fossa tumors, so it's like located at the back of the brain, those are more common, but those can also occur like in other areas such as like the cerebrum, so the front and the top part of the front and top part of the brain. Prognosis wise, that just depends, like I mentioned, on the tumor type and the location, and whether the tumor can be resected surgically. If it's like in a harder to reach area of the brain, or those that like, or it's more invasive, like spreading, if it's spread into surrounding tissues, it's more difficult to treat, right? Like just kind of think about that, like the location wise. um, there are different types of childhood brain tumors, which I included the chart from your textbook. There's medulloblastoma, brainstem glioma, ependymoma, and astrocytoma. I apologize. I butcher a lot of like names and words throughout our lecture. But yeah, you could just do a brief overview of those, like specifically like the medulloblastoma. That's the most common. Like I mentioned, how it's like at the back of the brain, cerebellum. And then you can read the other ones as well. Um, so you want to think about patho-wise. So like as these tumors grow, or tumor grows in the skull, that the skull has a limited amount of space, right? So as the tumor grows, it can start compressing the surrounding brain tissues and like the vital structures that are within there. It can block the flow of the CSF, so the cerebral spinal fluid, which can then lead to what? Hydrocephalus. It can cause that brain edema, so the swelling, and that increases the pressure inside the skull, so increased ICP. The increase in pressure, that increased ICP, that's going to lead to what? Headaches, vomiting, vision problems, probably behavioral changes as well. And there may be more specific symptoms just depending on where the tumor is located in the brain. Treatment wise, so again, depending on the type, size, and location of the tumor, there may be surgical, like a resection or total removal, maybe radiation. So if like the tumor can't be fully resected or like surgically removed, radiation can help like maybe sorry um decrease it in size, like shrink it. But typically, kids that are under 3 years old, it is avoided radiation because it can cause like long-term developmental issues. Other treatment choices is chemotherapy. So this is being increasingly used with the brain tumors, especially when like radiation is not an option. The chemotherapy can help shrink or kill the cancer cells. So that's an option. And then also, like for those kids that end up having hydrocephalus, a VP shunt. So I'm not good at saying this, but because I always say VP shunt, the ventriculoperitoneal shunt, that may be placed to help drain that excess fluid from the brain. Complications wise, is, like I mentioned, hydrocephalus, that build up in the fluid built up in the brain, the increased ICP, and then the brainstem herniation. So that pressure on the brainstem, that can be life-threatening, and the negative effects of radiation, right? So the long-term problems, the cognitive thinking issues, intellectual challenges, and possibly hormonal challenges as well. Sorry, I kind of went out of order here. But in regards to symptoms, what to look out for, thinking about the pressure changes in the head, I kind of mentioned some of them, the nausea, vomiting, the headaches, but also you want to think about the unsteady gait, possibly blurred or double vision, the motor weakness, maybe like weakness on one side of the body. And then I mentioned behavioral changes. So, maybe irritability, personality changes, but the younger children, delays in development, those are things to think about. And then also you may see like the cross-eyed, so the, what is it called, strabismus, or maybe like that involuntary eye movement, the nystagmus, or maybe where the eyes appear to look downward, so like the sun setting eyes, that's a big one. Head tilt or changes in sensation, and then maybe regarding the increased ICP for the infants, what are you going to be feeling? The bulging fontanelles, right? Diagnostic wise, there might be a CT scan, MRI, PET scan, lumbar puncture, biopsy. Those are all utilized to help confirm diagnosis. If it is going to be resected, so like if the kid is going to go under surgery or under anesthesia for surgery, you want to think about pre-op care and post-op care that includes, monitoring the ICP pressure, both pre and post-op, any medications that you need to help administer. So maybe a steroid like dexamethasone to help decrease that swelling in the brain. You want to think about pain management pre and post-op. What is the cause of their pain for each? For pre-op and post-op, does it differ? So how can you help promote comfort and decrease that level of pain? And then also education, both to parent and the child. So that's brain tumors. Let's talk about sarcomas now. So osteosarcoma, this is the most common bone cancer in kids. So this accounts for about 60% of all bone cancers. So it typically occurs in adolescents, males, and Caucasians. Usually affects the long bone. So the proximal humerus, the proximal tibia, and distal femur. So the symptoms often start with like a dull bone pain that gradually worsens, and that can lead to you're gonna see a limp or gait changes as the tumor grows, like that swelling and tenderness in the affected area that may be more noticeable to the physical eye. Like when you're doing your physical assessment, because the bone pain in when the adolescents are experiencing that bone pain, that can be linked to like trauma. So at first this osteosarcoma can be go undiagnosed because they may link it to some type of trauma, like they hit it or like they fell down. Treatment, this primarily involves surgical removal of that tumor, and then afterwards chemotherapy to help shrink it, and then help prevent the spread. So particularly in the lungs. And then radiation. This is typically not effective in osteosarcoma, so you may not see that really ordered. It's not as common, or I don't think at all. But in some cases, amputation may be required. So limb, but they want to try to do surgery where you don't do amputation if possible, especially in younger patients. You just want to think about disturbed body image and the way that developmentally and like psychosocially how that's going to affect them. So if it can be prevented, then of course they're going to do that, do like the limb sparing surgery. But for us, like as nurses, we need to assess for those symptoms, for the pain, the swelling, and that changes in gait, looking further as to like the reason of that, getting a detailed history, if we're admitting those patients. And then if they are getting the surgery, just like with the other, with the brain tumors, just providing that pre and post-op education and the cares for that, NPL, IV fluids, pain management, both pre and post-op, emotional support, providing resources like peer like support groups for the families. So yeah, we want to be there for both the parent and the child. Let's do Ewing sarcoma. So this is rare, but it's an aggressive bone cancer. This happens in children and teenagers. Typically affects the pelvis or the femur, so like the thigh bone. About 25% of kids with Ewing sarcoma will have the cancer spread to other parts of the body, so like the lungs, bones, or bone marrow. So it's going to metastasize to those areas. To treat it, okay, before treating, let's talk about symptoms. Okay, so what are we going to look out for? So the pain, the pain might start off more mild and gets worse over time. And sometimes it's so bad that it will keep them awake at night. So you want to get that detailed history from parents or from the child if they're old enough to assess for that, so you can chart it. And then swelling or redness, it might be around the tumor that you may see. And then as far as like diagnostic testing, CT scans, MRI, that will help to find out like where the tumor is and to see if it has spread, and possibly a biopsy. So like they take a piece of it, a small piece of tissue, to help confirm the diagnosis as well. Treatment wise, so they often use chemotherapy, radiation, and surgery. So if the Ewing sarcoma has spread, they may get stronger treatment like the chemotherapy, followed by the stem cell transplant to help again make those the body make new blood cells, right? The HSCT type of transplant. As far as management wise, our responsibilities will be to prevent injuries. So before treatment, you want to make sure that the kid doesn't put any weight on that affected bone to help avoid like some type of fracture, especially if they're super active. You want to encourage, rest and that protection of that specific limb. You want to help support any of the side effects of the chemotherapy or any type of pain relief. If they're feeling nauseous or fatigued, you want to help manage that as well. And then again, like with all the other ones, emotional support. So with Ewing sarcoma, kids are going to be in the hospital for a long time. So it's really important for us to be able to provide that emotional support. We want to be honest with them, especially the teenagers. They're older, they're able to comprehend more and understand more about this disease process and the treatment plan. But for like the younger kids, you will just want to think about, like, can we implement, since they're going to be in the hospital more long term, art therapy, music therapy. So they have dog therapy at a lot of hospitals. And then letting them go to the playroom if they can, or bringing them activities to do. So that's Ewing sarcoma. Let's talk about rhabdomyosarcoma. So this is a soft tissue tumor. Typically affects the head, neck, GU tract, genitourinary extremities. So this is highly malignant, and then typically it's diagnosed from 2 to 5 years old. Prognosis is based on the stage of disease. Typically they will present just depending on like the location of that tumor, like you can see in the chart right there, based on the location, they have symptoms related to that one. So for example, if it's in the bladder or prostate, you're going to notice your blood in the urine, so hematuria or urinary obstruction. If it's in the middle ear, you're going to notice drainage, pain, and facial nerve palsy. So just take a look at that chart and then you can read over those. Testing wise, to diagnose it, to confirm that diagnosis, there may be a CT, MRI, biopsy, bone marrow aspiration, and bone scan ordered to help confirm and to see where that tumor is exactly. That can help with that treatment plan, right? Can they remove it surgically? Do they need radiation? Do they need chemotherapy? So depending on their age as well, if they're going to implement certain types of treatments. And then you want to think about complications. It can metastasize, it can spread to the lung, bone, or bone marrow. So that's rhabdomyosarcoma. Also, again, management, you just want to think about, what do we need to prevent, what types, depending on where it is located, or like, is there going to be any abnormalities within labs? How do we prevent any further complications? So, and then also providing emotional support. Next is Wilms tumor. This is the most common type of kidney cancer in kids. So this is the second most common abdominal solid tumor in kids. So this typically affects young children between 2 to 5 years old. It usually only affects one kidney, but it can spread to other parts of the body. So the exact cause is unknown, but in some cases it may run in families or be linked to like genetic conditions like the Bequith-Wiedemann syndrome. This tumor, it grows quickly, so it's often large when it's like first discovered, but it can spread, like I mentioned, to other areas, so like the liver, lungs, diaphragm, lymph nodes, or abdominal muscles. And the prognosis, it just depends on how far the cancer has spread at that time of diagnosis. So this has 5 stages, so 1 to 5. Again, you don't need to know them exactly, just be aware that there are 5 stages within this type of tumor, Wilms tumor. So those kids with the early stages, so 1 to 3, their histology, like the type of the tumor cell pattern, is favorable. So favorable histology. They have a high survival rate, so about 91% is what your book says. As far as staging, that one is based on how far it has spread. So again, you guys don't need to know exactly for each stage, but just know that, again, that there are 5 stages, and possibly know that, like how I mentioned, the early stages 1 to 3, that's more favorable in regards to survival rates. So when upon assessment, in addition to, like the health history and stuff, you may notice an abdominal mass. Usually the parents will notice first. If the tumor is like rapidly growing, then they may exhibit that abdominal pain. They may have other symptoms like constipation, vomiting, poor appetite, or weight loss. Those are things to look out for. And then if they have some breathing problems, so if they're like respiratory distress, increased workup breathing, anything of that sort, that can possibly indicate that that tumor has spread to the lungs. You want to check for that blood pressure. So it says that like about 25% of kids with this type of tumor have high blood pressure. You want to look for more swelling in the abdomen. So is there any distension? Can you see the bulging mass? And then also palpate the lymph nodes for any swelling as well. Diagnostically, so testing wise, so an ultrasound, they're going to look at the tumor and the other kidney. A CT scan or MRI may be ordered to see if it has spread onto the other parts of the body, such as the lungs, as we talked about. Blood tests, it usually shows normal kidney function, but a UA, so urinalysis, might show blood or like WBCs in the urine. What other things? Treatment wise, so surgery, that's the main treatment. That's where they're going to remove the tumor and the affected kidney. So it's called a nephrectomy when they remove the kidney. And then chemotherapy, or in addition to radiation, or just separately, may be given either before or after the surgery to help shrink the tumor and to help treat if there's any spread of that tumor as well. Nursing management wise, again, if they're getting surgery, since this is that kind of treatment of choice for this type of tumor, you want to think about pre and post-op care, the education, helping manage those side effects, the medications that you can administer, and then the symptoms to look out for, and then also family support. All right, retinoblastoma. This is a cancerous tumor that starts in the retina. So that is like it's located in the back of the eye, right? Where that it's that light sensitive layer of the back of the eye. It is congenital. It accounts for about 5% of childhood blindness. Most kids are diagnosed by 5 years old. The survival rate is pretty high. It's 90% if it is just confined to the retina, though. There are two types of retinoblastoma, so non-hereditary and hereditary. Typically for non-hereditary, it occurs without a family history. It typically only affects one eye. Hereditary, this is inherited through an autosomal dominant gene, so it's meaning it can be passed on from parent to child, right? This can affect one or both eyes. This tumor can grow into, it's like the gel inside of the eye, so the vitreous cavity, causing the retina to detach. So, or it can spread to other structures, like the ones that surround it. So the choroid, sclera, or the optic nerve. As far as like how they will present, so they may have that cat's eye reflex. So that's usually the first sign. So it's that white reflection from the pupil. So this is called leukocoria, sorry. So it looks like cat's eyes in photos when you take it. So that's a key indicator of retinoblastoma. Okay, so take note of that, the cat's eye reflex. What does that look like? What does that mean? Other symptoms may be like the cross-eyed, so the strabismus again, the eye pain, maybe headache, vomiting. To diagnose, usually an ophthalmologic exam under anesthesia to help look inside the eye is performed to help confirm the diagnosis. A CT scan or MRI to check the tumor size to see if it has spread. And then also, if there's like concern that it has metastasized, then a lumbar puncture or maybe bone marrow aspiration may be done as well. As far as like after diagnosing, this is classified based on size and extent of the tumor. So it's classified with letters, so A, B, C, D, E. So A through E. Just like the other ones that within like the stages and the classification, you don't need to memorize it, but just know that there are different classifications. It's from low risk to very high risk. So the goal for treatment is to help eradicate the tumor, preserve the vision as much as possible, and provide like a good cosmetic outcome, right? Like these kids are growing and you want to think about that disturbed body image and the longevity of it. So treatment options, typically chemotherapy, radiation, laser surgery, cryotherapy. So that one's different from the other ones. So cryotherapy, that is where they freeze the tumor. And then in some cases, they may do a full removal of the eye, so an enucleation, if it is necessary, right? So because we always want to try to provide and preserve the vision first and foremost, and then also provide that good cosmetic outcome. But if needed, that will be done. Again, thinking about pre-op, post-op care. If there is like a total removal of the eye, then you want to think about keeping that dressed and clean. Medications that are prescribed to help prevent infection. And then any of the side effects of the different types of treatment. So like the chemotherapy, what kind of medications can we administer for that? What other things? Regular follow-up is very crucial too in post-op care. So eye exams, they're gonna happen every 3 to 6 months until they are 6 years old, and then after that it's just yearly. But if the eye was fully removed, like the prosthetic eye will be fitted later to help with appearance. That can be an option to help with that body image. And then providing support, right, for the patient and the parent, so they can understand, like, especially if the eye was removed and they're getting a prosthetic eye, you want to be able to help provide that support and education on how to care for that prosthetic eye if needed. Okay. Lastly, let's talk about reproductive cancer in adolescents. So reproductive cancers such as cervical cancer and testicular cancer, those are becoming more common in teenagers actually. So early detection, it's just crucial because early diagnosis, that can help the chances of successful treatment. So starting screenings in the adolescent years can help form those healthy habits that can be more long-term as they grow into adulthood. So first, let's talk about cervical cancer. So this starts in that lower part of the uterus, right, the cervix, and that can be prevented in many cases. So risk factors wise, though, adolescents are at increased risk if they have early sexual activity. So they start having intercourse at a young age. Sexually transmitted infections, so especially human papillomavirus, so HPV, and then if they've had multiple sexual partners, right? So prevention and screening. You want to educate parents and the child about HPV vaccine. During your immunization week, when you guys talked about it in theory class, the HPV vaccine is not just for sexually transmitted infections or diseases. This helps prevents most cases of cervical cancer, so it's recommended for both girls and boys, not just girls, and starting typically at age 11 years old. And then pap smears, getting that's a screening tool that helps to look for those abnormal cells in the cervix. That is an important part of like that prevention of the cervical cancer. So this typically pap smears, will begin 3 years after becoming sexually active. So that's something to educate about. And then typically, like once kids are reaching adolescence, you will, like, the providers during well child visits, they will provide ask questions without parent at bedside or in the room, so that the child is more willing to be honest and talk more about if they're sexually active, and then the heads assessment, which and then now let's talk about testicular cancer. So this is more rare in teenagers, but it still can happen in young men. So this is one of the most treatable cancers if it's caught early. So you want to educate on self-examination. I know it can be uncomfortable for both the provider and the adolescent, but this is something that can definitely help prevent. So just encouraging them to check their testicles regularly. So once a month for what are you going to look out for? Any unusual lumps, swelling, pain. So just educating them on that testicular self-examination, and that you could tell them that this should be done after that warm shower, and they should be familiar with their baseline normal size and shape of their testicles so that they can compare. I know, again, it's a more uncomfortable type of topic to discuss, but I included the picture on how to perform it, and then how I mentioned how performing it once a month after a shower. So after the shower, because that's usually when the skin is relaxed. And then after that, gently rolling each testicle between your fingers to feel for the lumps or changes or any changes. That's why it's important to know the baseline, for the adolescent to know their baseline so they can see any changes. And then you're going to, again, check for those unusual lumps, swelling, or heaviness. And so if anything feels abnormal, then that's when they should they want to mention that, like, or seek a healthcare provider right away. So that's something regarding testicular cancer. And that completes the presentation or the lecture. Let me know if you have any questions. Feel free to contact Dr. Reedman or I. You can always set up like a Zoom or in-person session with me or Dr. Reedman, okay? So have a great week. Have a great night. I will see you soon.